Welcome, everybody. Thanks for joining us today. This is Ask the Expert for LMNA or laminopathies. Our agendas today is going to be, we're going to introduce our experts. We'll have research questions followed by care questions, and then a couple of brief closing remarks given the time. So these are our expert panelists for today, but we will have them all introduce themselves. So Gisèle, would you like to start?
Yes. Hello, everyone. I'm Gisèle Bonne. I'm a researcher here in Paris at the Myology Institute, and I work on the research part, trying to understand the mechanism of the mutation, how they give rise to the disease, in order to elaborate and test some therapeutic approaches for the disease.
I think you're being humble. You're basically the mother of LMNA. So.
Yeah, let's say I identified the first mutation 30 years ago.
Yep. Anne?
Hi, I'm Bertrand. I'm working in the same institute with Gisèle. We are working together, in fact. So we have the same objectives, so trying to understand the variety of mutation, how they give rise to mutation, to pathology, and trying to find therapies for patients.
Great. Ignacio?
Hi, this is Ignacio Perez de Castro from Spain. I lead a gene therapy unit at the Instituto de Salud Carlos III, and we are mostly focused in trying to develop gene therapies, especially based in CRISPR, for the treatment of LCMD.
Saverio?
Hi, I'm Francesco Saverio Tedesco. I'm a pediatric neurologist working in London, in the UK, across 3 institutions. I work at University College London, Great Ormond Street Hospital for Children, and the Francis Crick Institute. I have a particular interest in congenital muscular dystrophies and congenital myopathies, and the focus of my research program and lab is to build up in a way, complex models of those conditions to study them in the dish and then develop potential experimental therapies using those.
Great. Thank you. Rotem?
Hi, everyone. Rotem Orbach. I'm a pediatric neurologist. I work in the neuromuscular and neurogenetic disorders group at NIH with Dr. Foley. A specific research focus on imaging biomarkers for congenital muscular dystrophies.
Kaitlin?
Hello, I'm Kaitlin Batley. I am a pediatric neuromuscular neurologist. I practice at UT Southwestern in Dallas, Texas.
Hank?
Yes, hi, I'm Hank Meyer. I'm a pediatric pulmonologist. I've been involved in the pulmonary aspects of neuromuscular care for a number of years and have very passionate about supporting respiratory health in patients with neuromuscular disease.
Thank you. Reghan?
Hello, I'm Reghan Foley. I am a pediatric neurologist, neuromuscular specialist. I work at the same institute as Dr. Rotem Orbach. We're at the NIH in Bethesda, Maryland, where our group has this particular focus on congenital muscle diseases and especially congenital muscular dystrophies, where we do clinical research studies.
Gus?
Hello, I am Gustavo Dziewczapolski. I'm the scientific director at CureCMD.
And I'm Rachel Alvarez, the executive director at CureCMD. All right, let's get into the research questions, Gus.
Okay, perfect. So let's start with trying to clarify the different names for LMNA-related disorders or laminopathies. We hear LCMD, EDMD, or Emery-Dreifuss muscular dystrophy, or Limb-Girdle muscular dystrophy 1B. So can you clarify the diagnostic criteria and the spectrum of these diseases? And the second part of the question is if all LMNA-related muscular dystrophies have cardiac involvement.
I can start by the different identification, and we'll let Reghan focus more on the clinical symptoms. So all these muscular dystrophies are linked to LMNA gene mutation. And there is, let's say, roughly 4 big categories for muscular dystrophies. Those who are starting very early, before 2 years of age, that we call LCMD, for LMNA-related congenital muscular dystrophies, that are the most severe. They have both skeletal muscle and cardiac disease. Then you have Emery-Dreifuss muscular dystrophies. They start a bit later, around during childhood, for the muscular symptoms that are associated with contractures and typical specific muscular weakness and wasting. And by adult age, they also have cardiac disease. Then you have limb-girdle muscular dystrophy, formerly called type 1B, but limb-girdle muscular dystrophies that are rising a bit later for the muscular symptoms by teenage or adult age, or sometimes a few cases can start during adult childhood, but the same, the muscular weakness is more proximal this time, and the cardiac disease appear again around adult age. And for limb-girdle muscular dystrophy, there is less contractures. These are the 3 categories that have muscular weakness and wasting. And the 4th category, we used to say, is the isolated dilated cardiomyopathy with conduction defect, which is the cardiac disease that you can find in every category of muscular dystrophies that I just highlight. So those are all related to the same gene, associated with different mutations.
Yeah, so one more thing, because that also we know that LMNA, or there are laminopathies that are not skeletal muscle related. Can you just briefly mention those two?
So there is also other diseases linked with mutation in LMNA genes. Some are associated with lipodystrophy, partial lipodystrophy, which is a defect of adipose tissue and metabolic syndromes. And sometimes there is slight overlap with the different disorders. And there is also mutations that give rise to premature aging syndromes. The most well-known are the Hutchinson-Gilford progeria that arise in the early years, after 6 months after birth, usually, and evolve quite rapidly, and with premature aging.
Great, thank you. Reghan or someone? Yeah.
I'm going to add, for the congenital muscular dystrophy subtype that is related to LMNA, or as Professor Bonne mentioned, like the LCMD or LMNA-CMD, we have to acknowledge the wonderful impact of our colleague, Dr. Susanna Quijano-Roy, who in 2008 actually really enumerated and described that it's de novo, meaning variants in the LMNA gene that have not been inherited from mom or from dad that occur in the child. Those children present congenitally with the congenital muscular dystrophies. That LCMD is always de novo and has a really distinct phenotype. It does always have cardiac involvement, and we'll talk about that more. And it's a risk for atrial arrhythmias. And so that is well known. And Professor Bonne is the mother of LMNA. Well, the father of cardiac LMNA was Professor Karim Awabi. He's not here right now, but always available to give us guidance on this area. But he's done extensive research in the cardiac implications for laminopathies.
Thank you. So let's jump right away to the hard research studies. Most of the questions were related to gene therapies. So can you describe the experimental gene therapies that are around in the field that could be used for LMNA?
Well, maybe I can start mentioning something. Well, the mutations that lead to this disease are dominant negative mutations, which means that only one copy of the mutation is affecting and causing the disease. and in a dominant way. That's why, I mean, the use of CRISPR can be modified in different ways, or CRISPR can be used in different ways in this for this disease. An obvious one that we started a long time ago to investigate was to use CRISPR in order to eliminate specifically the mutant allele. This could be a risky strategy because if you also have activity over the wild type one, could be dangerous at some point. Plus, there are some researchers or some previous research claiming that the only having one copy of LMNA could be also no good for the patient. In our case, that's not the situation. So we demonstrated that this could be a good strategy to eliminate specifically the mutant allele and just leave one wild type allele. Of course, there are now technologies based in CRISPR 2.0 that could edit the DNA. Instead of eliminating the DNA, you can modify the DNA, you can modify the mutation and revert to the wild type situation or to the normal situation. And this is something that is also working, at least in our case in cells, and we are trying to verify if this is working in vivo, in animal models. And a third possibility based in CRISPR 3.0 would be to use prime editors. And prime editors are able to do the same thing, are able to erase the mutation and write now the normal nucleotide. So these are the three possibilities based in CRISPR. And of course, there are other possibilities that we can think about, but I could say that one of those is going to be the one that is going to be used in this disease at the end.
And
Yeah.
that approaches are very early in research development, right? Or
yeah, I would say that in all the cases, at least as far as I know, the majority of the strategies are right now in a preclinical stage, and probably we are going to talk about that later. But the majority of them are waiting for the wonderful delivery strategy. I think that the delivery probably is going to be is right now the bottleneck, because one way or another, all these strategies are working at some point somehow. But of course, using the delivery system that we have right now, they are not good enough. Just to summarize, so maybe we need to improve either the CRISPR technology or strategy, or the delivery system, or both of them. So that's why we are right now still in the preclinical stage, I think.
Okay. Other gene therapy development? Sorry,
Yeah.
go ahead.
Sorry. Yeah, we are also developing some gene therapy for LCMD, and we are using another technology from Perez de Castro. It's based on, as he said, we have to remove the expression of the protein that is mutated, but we have to reach the normal level of the protein. So we have to combine a strategy to reduce the expression of the mutant and another strategy to increase the expression of the wild type. So we are trying this also in a mouse model. So we are just at that step now. For these, there are different approaches that are possible that I won't explain, but it's linked to different mechanisms inside the cells, mainly to decrease the expression of the toxic protein. There are different versions of this, as there is for CRISPR technology.
Maybe I can also add a couple of words if there is time.
Yes.
Just to say that, yes, indeed, as has been just said, gene editing is extremely promising, and we're also doing work in that direction. And to link to what Ignacio was just saying, that there is a lot of work going on also for the delivery systems that were mentioned before, in the sense that as for other muscle diseases, there are more and more engineered viruses to make them unharmful, most of which are called AAVs, that luckily for this condition, they are quite good at targeting both the heart and the muscle. So in a way, we still have to do a lot of work there, but the good news is that those viruses that have to deliver those gene editors or other
And I think you just started to address that, but so gene therapy is if you want to correct the pathology in the heart and in the skeletal muscle, there is a chance to do a combinatorial gene therapy for both, or it has to be two different approaches?
Well, I think that right now we were mentioning that the delivery system that we have right now, they are able to approach to the two system, into the two muscles, and both the skeletal and the cardiac, because they are targeting the striated muscle, so they are good enough in order to do that. So I would say that for the AAVs, you don't need to have two different strategies.
Thank you. Can you comment on what research studies are probably most closer to moving to clinical trials, or is very early to predict that?
There is some ongoing studies that use type of it's not to correct the mutation per se, but it's to try to counteract against some consequence of the mutation. And there is a group in Singapore who try to disrupt the link between the cardiac cells, the interior of the cardiac cells, and the nucleus, where is located the gene product, the lamin, that are abnormal in the disease, in the cardiac cells. So what they try to do is to disrupt the link between the nucleus and the rest of the cells, to release some forces that are abnormally appearing due to the mutation. And doing so, they correct a bit the function of the cardiac cells. And so there is a company called Nuevocor who is trying to initiate, who's setting up a phase 1 trial to test these approaches to release these forces that are around the nucleus of the cells.
Great, thank you. And so that kind of gene therapy will be like a mutation agnostic, right? Because it's not targeting the LMNA directly.
It will target whatever mutation it is. So you do not have to make a tool per specific mutation. It's mutation agnostic. And they have already demonstrated in a number of different mouse models that is effective and prolong the lifespan of the animal model. But working in animal model for a certain period of time doesn't mean that it will translate with the same type of effect in patients. That's why they are just at the present time designing a phase 1 trial. And I think they try to get the money for that as well.
Great, thank you. So can you comment on any other research studies going on that are important for the laminopathies?
For the going towards to any therapies, there is we have discussed a lot about the gene therapies that aim at correcting the defect of the gene and to correct the mutation. I just mentioned another type of gene therapy that try to stop the consequence, but you can try also to stop the consequence of the mutation by using small molecule or chemicals, and there have been a number of studies that has deciphers the abnormal signaling pathway that as a consequence of the mutation. So all what's happened wrong in the cell, and so you can slow down the consequence, the progression of the disease by using these different molecules. There have been a few years back a phase 3 trial with an inhibitor of P38 that target the MAP kinase pathway. And I know that there is still ongoing research in that direction. So there is different lab who try to make high throughput screening using cell model. So to try to tackle the different pathways that we have identified that are abnormal due to the presence of the mutation, try to counteract this defect and see if we identify the molecule that we can repurpose and to speed up the pathway to any trial.
Are there already any lead compounds that, or we are in early stage?
None that I'm aware of, but usually those things are not publicized by the company before they get. There's been a number of work published using the cells, the iPS cells derived in cardiomyocytes or in other muscle cells, like what is doing Saverio Tedesco, and they use this dish systems, either in 2D or 3D, to make some high throughput screening and to try to modulate some pathways that have been identified as abnormal. For the cardiac disease, there's been several papers that get out highlighting some channels that are abnormal that could be tackled, but always it's a story. Then you need to translate this further, and so far that's not been a great advance, I think, to my point of view. Maybe
okay, and you mentioned the work by Saverio, and we already mentioned about model systems for the disease. Yeah. So I think it's a good time to explain a little bit more about the different models for the disease that we have, and maybe you can start, Saverio.
Yeah, thank you, Gustavo. There are again, luckily for the field, plenty of different models from animal models, mostly mouse model, laboratory mice, to other. There are more recently also what we call model organisms, which could be like fruit flies or even worms. More recently, that can model laminopathies. And then there is another big branch of work and groups that are focusing more on more sort of humanized systems, including us, where they essentially can be either cells grown in a simple culture dish from biopsies of the patients, or more like recent techniques where it's mostly based on the iPS cells that Gisèle was also mentioning before, and those are super stem cells, if you wish, if you want to imagine what they are. They are stem cells that are turned from muscle cells or from skin cells into cells that can eventually produce heart cells or muscle cells, and then you can build up in more complex systems, almost like an avatar, if you wish, of the patient, of the individual in the lab, where you can look at more complex aspects like the contraction of the muscle fibers, the shape of the of the nuclei of the muscle fibers, which is obviously something of interest in this condition as well, and so on and so forth. And that has the advantage that you can keep these cells in the culture dish for several days or several weeks as well. That is something that is not possible sometimes with sort of older systems to grow the cells. And my particular interest in this condition and in this research area is to do exactly that. And we use these systems both to understand the mechanism underlying LCMD and other laminopathies, but also to try to use them to not only model the condition, but also model the therapy or the delivery of the therapy, connecting to what we were saying before.
Thank you. I think, Ignacio, you have done a specific mouse model for a specific mutation.
Yes, actually, we have the R249W knock-in mouse model still pending to be published. I don't know for how many years we are going to wait to publish that mouse, but just you to know that we have the mouse and you can use it. And it's a really good mouse modeling in terms of it recapitulates very well the cardiac phenotype. So we have followed that animal with bioechocardiography, and it's amazing. At least for the cardiologists, is quite good for the study of this disease. And actually, we have used already the mouse model in order to validate some of our gene therapy strategies. So I think that actually we also still pending to be published. We use this mouse model to test the P38 inhibitors, the RE797, and I have to say that it was surprising that those inhibitors didn't work at all. Actually, they were kind of dangerous and more aggressive than the phenotype. So yeah, so that's what we have right now, and it's quite useful for us.
I think that this is a good example for the audience that there is not an ideal model system that you can study everything in that system. So that's why it's important, and many times we as patient advocacy associations that we give grants many times is to develop more of these models, right?
To complete the point of Ignacio, there is other animal model, and maybe I let Anne detailing a bit more. Just to say that it's not only one single mutation. Of course, we cannot make a mouse model for every single mutation, but there is multiple model, and Anne can comment on that.
Yeah, we have published this model more than 10 years ago. It's a deletion of the lysine 32, and it's also a mutation that is found in LCMD patient, and the mouse recapitulate all the phenotypes that we have that we are aware of in patient. It's really severe, and so it's also a model that we can use to test the therapy, and that's what we are doing. So after we test our therapy in vitro, we always go to the mouse to test it. And these mice also present another phenotype when it has just one copy of the gene that is mutated instead of two, and it's isolated dilated cardiomyopathy. So the one of the four phenotypes that Gisèle described at the beginning of the meeting.
Great, thank you. I think for time reasons, maybe the last question we can address is research efforts on LMNA in different countries going on, and so audience is interested in knowing if there is a C-load by country or if there is a good communication between groups.
We are highly collaborating all together. We know each other. We share tools. I've sent cells to Saverio to set up some cell line. We shared with
Ignacio.
We share with Ignacio cells again to establish the line, etc. And working on ultra rare disease, there is no other way than working together to speed up all the research. Otherwise, it would be a loss of money, a lot of time, a lot of effort, a loss of effort from everyone. And we are highly collaborative, and we try our best to share. And we meet at laminopathy meetings, and there will be the fifth one very soon. No, in May, next year. We are trying to prepare it, and we had one last year. So every 2 other years, we meet all the community on laminopathies to share expertise, advances, and the fact that we share all the different research on the different type of laminopathy is also very important because we learn from each other. We have complementary expertise, and it's because we collaborate all together that we can go faster.
Great, yeah, and you mentioned the laminopathy meetings. I was very glad to be able to attend a couple of those, and it's not only LMNA CMD, but all the laminopathies. So this is learnings from other aspects of the LMNA gene. Any other comment from the researchers?
I'd like to ask Reghan to briefly comment about one aspect of research is natural history studies. So you kind of explain what that is and what's going on in that area.
Sure. As we prepare for the therapies that are in development, as they get, as they progress towards the future of clinical trials, we try to improve clinical trial readiness, and that relies on understanding the natural history of the condition really well, defining and validating outcome measures, be it biomarkers that are blood or imaging or motor scales, pulmonary function, and then also optimizing clinical care. We were fortunate, along with the team there based in Paris, Professor Gisèle Bonne, to do a retrospective natural history study. Again, retrospective looking back, but that was looking at 151 patients with LMNA, and 81 of those had the LMNA-CMD subtype. It's a very important work. It spanned across 23 countries to at least understand what we know so far, what we need to look at more carefully. And we identified that we need to look at more carefully the early years, the first, particularly the first 5 years or so of the condition. And so we have planned to include in a natural history study at the NIH for the CMDs to include patients with LMNA, a baseline visit, and then a follow-up at 1 year time with the goal to kind of better identify the natural history during those years. We do know there's variation amongst LMNA CMD patients, those that may get to taking steps independently and those that don't, and studying in more detail is helpful. Again, international collaboration, as Dr. Gisèle Bonne said, very close collaboration internationally.
We continue to register every patient who wish in different registry, and there is a series of registry that are established now in US, and there is others in Europe, and we are again aiming at connecting all the different registry together, just to be able to speed up again the description of the natural history and be prepared for any trial whenever it happens.
Thank you. So, Rachel, I think it's time to move to the care questions.
Yep. Thank you very much.
Thank you.
So my first question regarding care is, what are the key facts that we should be informing care providers like pediatricians or primary care providers during routine exams or routine care, and also emergency providers during acute care scenarios? Kaitlin, we'll start with you because you had a really good answer on the last one.
Sounds good. So I think one of the most important things is that we're kind of always prepared to help maybe an emergency room physician or a primary care physician who is not a specialist in neuromuscular disorders to know kind of where to find the information that they need. As a generalist, they have to know at least a little bit about almost everything. And so it can be very challenging to keep up with all of the different guidelines for different conditions. And so what I usually do for my patients with congenital muscular dystrophies or myopathies is I actually print the Cure CMD guidelines, and, I go through and I highlight the things that are very important. If, I'm like, this is the page that you show the emergency room physician if you're going in for a respiratory issue. These are the guidelines and standards of care. And so that way they know exactly where to find things and what to do, because otherwise, they might not have time to, get online and do their research, and especially in an acute situation. And then also we're fortunate working at a large university that we have a 24/7 neurologist on call that they can always reach out to us. So I typically encourage our families to also, provide that contact information and say, hey, if you need help, if you need guidance, this is my neurologist's phone number. So I think being able to advocate for yourself or for your child to, let them know that there are these guidelines and where to find them, I think is really important.
From your perspective, what do primary doctors need to know?
That's a challenge because, as was just pointed out by Dr. Batley, primary care providers know a little about a lot, and a highly specialized and rare condition such as this. I don't think it's reasonable to expect that they're going to understand how to handle an acute emergency. And so what I recommend to my patients is, first of all, review in great detail with them what an acute management plan should be for respiratory issues, and then recommend that should they go to the emergency room that they call us first, but also have their go bag to bring their equipment and be ready to provide strong suggestions, if not demands, to the personnel in the emergency room. And I think it's, just have to be practical. If you're going to an emergency room that's not affiliated with a large medical institution, such as where your neuromuscular care might be, you should expect that they're not going to know necessarily how to properly manage an acutely ill child with neuromuscular disease, and go in ready to provide some guidance, and hopefully with to receptive ears. And if there's less receptiveness than you would like, then certainly presenting the care considerations document that Cure CMD provides, and an offer to a suggestion to call the treating physicians at your child's or your medical institution.
Great. Anybody else have anything? Okay. Diet, medication, and supplement recommendations. And then there's another question specific to that about iron level concerns. Rotem, do you want to start?
Yeah, sure. For diet and supplementation, obviously that needs monitoring and very tailored to the specific patient to help with bone health, vitamin D, look at calcium, iron level, ferritin, all of that, just to optimize nutrition health, very important. And then what was the second one? The second question?
I think specifically about iron level concerns. Is that something that you see in LMNA patients, or?
About what concern?
Iron level.
Iron level. I'm not familiar with any specific about that. I don't know, maybe someone else here on.
I also haven't seen low iron levels associated specifically with LMNA-CMD. I think you need to kind of get an individual, workup to see why that would be, but not particularly associated that we are aware of.
Okay. Anything else on diet, supplements?
The only thing I can think of is maybe in regards to the iron is, we always want to make sure that we're not missing causes of fatigue or muscle weakness that could be kind of more general and not specific to the muscular dystrophy. So for instance, if you're very anemic or have a very low ferritin level, then maybe you might be more tired and more fatigued. And obviously in someone who's already at risk for that because of their muscle disease, we don't want other things too. So sometimes a thorough assessment for those kinds of things, if we're seeing like a worsening of fatigue, could be warranted.
Maybe another comment that's worth mentioning is all the wide array of supplementation that are out there to help mitochondria and to help kind of muscle endurance. And overall, those are safe. And many times patients are reaching out asking if they can try those. And the general answer is yes, but you should be very minded when you take those for side effects, whether it's actually doing less benefit and more harm to you and to your general kind of feeling. And also some of them, like creatine, you should really hydrate well and be aware of what can go wrong.
Great. Okay. Kind of in that area, there's anecdotal evidence that long-term use of steroids in LMNA can be useful. Can we talk about that? Can we talk about the indicators, the risks, and like where do we start with dosage?
Maybe I can start and others can take the ball. So we do know, mainly from our colleague, Dr. Sana Kuhana-Roy, who's at a pilot of steroid use in children with the LMNA-CMD subtype, that the patients that are showing kind of a signal of responsiveness to the steroids are those patients that have achieved the ability to walk independently. And if steroids are trialed while they are ambulant, and again, in a setting where there's oversight from a physician who's prescribing the steroids and there's an assessment of motor outcomes and motor abilities, and there's also a discussion with the family about side effects versus benefit, it can be trialed. We have not had a formal clinical trial across sites looking at this, but there is some evidence that steroids can play a role in particular patients, those that are ambulant, again, under the care of a physician watching carefully.
What are those side effects?
Well, maybe I'll pass the ball to my colleagues who probably have a lot of good experience with the side effects too. Yes.
I can take that one. So steroids are something that we very commonly use in Duchenne muscular dystrophy, which is, very in our world, common condition that we treat. And so that is always the conversation is, balancing our benefits with our risks. And so steroids can really affect the body systemically. I'd say the most common side effects that we see are weight gain, which of course can be particularly impactful for someone with muscle disease, because if you have muscles that are weaker, then adding excess subcutaneous tissue and adipose tissue can make it harder to move. So kind of balancing that can be really important. We can also see some behavioral side effects, things like irritability or worsening mood symptoms. That can be really impactful for a family's, day-to-day life as well. And then we also know that long-term use of steroids can affect the eyes and causing cataracts. It can affect the bone density and put you at increased risk for fractures, which can limit mobility as well. And then we also know they can suppress the immune system and make you at higher risk for infections. They can affect the stomach and cause gastritis. There's unfortunately a very long list. And so it takes, careful assessment of risks and benefits when we decide to use steroids.
So probably the recommendation is if you hopefully have a multidisciplinary neuromuscular team, to have that conversation about whether or not to start and how to start and what the dosage would be. Probably not ideal initially with a primary care physician who doesn't necessarily know LMNA. Yeah.
Yeah. In addition, there's, of course, adrenal suppression, which can be a big issue during an acute illness. And all of our Duchenne patients, have a plan for managing that. So if it were to be used, it really needs to be done with proper surveillance and with an endocrinologist helping out.
Okay.
I also wanted to briefly add that, although unfortunately we don't have a kind of an international protocol or guideline yet for steroid use in LCMD or in other laminopathies, there is a lot of effort to try to go in that direction. And a lot of us are already talking and discussing this with internationally to, again, come back to what we were saying before, particularly also again with Susanna, as we briefly mentioned before, and I think there is another potential interesting and promising development that it will happen in the coming years, because I think there is sufficiently promising data to some extent, although very preliminary, that there could be some room for benefit.
Ignacio.
Yeah, if I may. Since you are here, so I can ask a couple of questions in my case. So I wonder if you see differences between male and females in the treatments with the corticoids or not.
Not that we've heard so far from our colleagues who are using it more extensively. Yeah.
I
Okay.
think, if I may, although I'm not a clinician and I'm not following patient, we had a discussion with Saverio recently with Susanna, and the question was asked, and it's not that evident. It's there is no gender issue there, and Susanna is trying hard to put together all what she had already observed to make a paper and prepare something to make a protocol international, as what we did a few years back for the registry. So try to push in that direction.
Actually, if may I, so I have another question. So which one are you using? I mean, are you using vamorolone? Are you using which corticoid is the most frequently used right now?
I would just say anecdotally from those teams that have been in contact with me, most have been trying prednisone, but we have had discussion of if vamorolone is available, that would be also an option to trial.
Yeah.
But
They're having
vamorolone, at
trouble.
least
They're having
yeah,
trouble getting
vamorolone,
attribution.
vamorolone is not yet available for pediatric use, at least in Europe. I don't know in US.
Yeah,
And
they're having
even
trouble
though-
with the primary indication that trial was about. So getting it to LMNA is going to take a while if we get there, I think. But it would be lovely. All right, anything else on steroids? Okay, physical therapy and
Rachel, sorry
occupational.
if I interrupt you.
Yeah.
Maybe just one thing came to my mind, vaguely related to steroids as well, which is a question we get asked often is also, given that there is a metabolic aspect of laminopathies, particularly around, we mentioned the lipodystrophy, for example, before, whether the steroid might have an impact on that, whether the fact that we know that there is some aspect of the metabolism that are potentially impacted in laminopathies, whether this could be a problem with the steroids. And it's very difficult to answer that question now because of the small numbers that we have. But it would be an important matter for future studies, including the fact that luckily the standard of cares are getting better and better, and so this also comes with better life expectancy and quality of life and so on and so forth. So we might be also, to some extent, we're probably also seeing the emergence of new aspects of these conditions, and we're also working hard with other colleagues to identify whether there are some cases where you have a bit of both, a bit of muscle problems and metabolic problem, or muscle problem and adipose tissue problem, like in the lipodystrophies. And so that would be another important aspect to keep in mind when the steroids are going to be used more routinely.
Okay. Can we talk about physical therapy, occupational therapy? How often and what areas to concentrate on? We unfortunately don't have a PT with us today, but I think some of our neurologists can help with that one. Kaitlin, do you want to start?
Yeah, I can start off. So I think that's going to be very individualized just based on the current needs and muscle function status of each patient. But I think it's important that that's continuously reevaluated. And I think that the goals can change over time, but I think there's always a benefit to having some sort of therapies that are, either intermittent or ongoing, and that can help with things like stretching and joint range of motion, increase utilization of things like standing frames, and help getting in those kinds of devices, as well as optimizing orthotics and hand splints and kind of whatever might be needed at the particular time. So I think having a frequent check-in with therapists is really important. We're fortunate to have some in our clinic, so they can check in on our patients every 6 months or however often they're coming to see us, to kind of reevaluate over time.
Okay. Let's talk about cardiac. First, I would like to define the difference between an ICD and a pacemaker. what is an ICD, and then kind of what are the indicators that we need to have an implant, and what are the risks for stroke, indicators for sudden death, and risks for exercise. That's a lot, but let's talk about cardiac in general.
All right, Rachel. So the first thing to say is when you're diagnosed with LMNA-CMD or LCMD, probably the most important thing to be aware of, probably tied with pulmonary, is proactive cardiac monitoring and by a cardiologist who is an electrophysiologist. And as Professor Gisèle Bonne mentioned, we are a tight community. And so if you have questions, reach out. Because it's very important that the cardiac team locally knows that there are specialists in the world who understand this condition. So the risk for atrial arrhythmias is real. There needs to be Holter monitoring. You cannot Holter monitor too long. Longer is better. So many children have a link monitor, implantable cardiac monitor under the skin that's monitoring the heart rhythm proactively and gathering that data. And we clearly know that implantable cardioverter defibrillator, an ICD, is necessary. A pacemaker is not sufficient. It has to be implantable cardiac defibrillator. And the age of that and the details of that and the conversations that happen with the cardiac team, it's best to have a colleague in the LMNA field to make sure that we can provide that data. And there's extensive data for LMNA and arrhythmias. And so you should never navigate that alone. There are some very well-intentioned cardiologists who will tell you a pacemaker is sufficient. We will politely but strongly disagree. We know more. So don't navigate alone. You have all of us at your disposal to help support you navigate that very important issue. And you can't start monitoring too early. And we have a lot of good natural history data to support our recommendations.
So for later onset laminopathies, we pretty much, as soon as you get a diagnosis, cardiac needs to be begun monitoring immediately, right?
Yes.
Okay. And echocardium and Holter monitor both, right?
That is correct. Both. That's a key point. Yes, both are very important. Yes.
Great. Anybody else want to say anything about cardiac care? Such an important aspect of this condition. Okay. Let's talk about pulmonary care. Pulmonary function testing, sleep studies, when and how often, and what are the indicators that breathing support is probably needed?
Well, we have normative data for pulmonary function, meaning that once a result is produced, it can be put in the range of normal, going from 3 years well up into the late 80s, early 90s. And so from a practical standpoint, most kids are able to do pulmonary function testing at about 5 years of age. There's no similar testing for younger children or infants. However, one of the things that is important is to screen for respiratory insufficiency, and that's done by doing a sleep study or a overnight capnography or carbon dioxide study. The question really is when to start looking, because it's not really practical to just do testing at a set frequency just to make sure that breathing is adequate at night. And so instead, what we try very hard to do is look for signs of more rapid decline or problems with poor sleep, fatigue during the day, morning headaches, to determine when somebody may be at risk of having respiratory insufficiency at night, and then getting a sleep study to confirm it. The other reason that we don't recommend, it's hard to recommend doing regular sleep studies, is that they're very hard to come by. And at my institution, where we probably have one of the larger pediatric sleep labs in the country, if not the world, there's a 9-month wait to get a sleep study. And so, unfortunately, there are lots of kids that have large tonsils and snore, and so lots of competition for getting a sleep bed. And so the ideal approach would be to have an ongoing conversation with the respiratory provider and coming up with trying to identify concerns that may go along with respiratory insufficiency. And at that point, get a sleep study.
I'm just going to tag on to add to Dr. Meyer's comment, is that for the children with the LCMD that do not attain the ability to walk, most will need to be on non-invasive ventilation. We know from our international data by 7 years of age. And so we know that, and you can bring that data to your local team as well to keep that in mind.
Okay. We have a question about pregnancy. So affected individuals who are pregnant, particularly with a cardiac implant, are there any concerns that they need to be making their care team aware of? Reghan, do you have anything?
Wow, I don't know. I think I'm going to need the help. I'm going to phone a friend here. So I've not actually encountered this situation myself yet. I don't know if anyone else has or is a comment on how to.
Neither do I, but I think it's very obvious it's a high-risk pregnancy, right? And that should be followed with a high-risk appropriate clinic that is supported by cardiologists with all the attention to make sure that everything is going well. But from what I've known, it can go very well. So like just be ready for it and monitor. And
okay, great. We're at our time today. So thank you so much, everybody. For the questions that we didn't get to, we will probably be creating a written document and we may be reaching out to some of you to help with those answers. But thank you so much for your time. Thank you much for your dedication to this subtype. We're always grateful and lovely to see you all.
thank you.
Have a good day. Good weekend.
Thank you very much.
Bye.
Thank you.
Take care.
Thank you.
See you guys.
Bye.